Welcome back to part 2 of the chapter on the heart. The first part went long, so I was dramatic in cutting things for this second part. This will be briefer. We're going to examine some arrhythmias, departures from normal sinus rhythm. I'll remind you, we're going to be looking, this is the last slide from part 1. We're looking at the ECG or EKG. There's a P wave that corresponds to depolarizations that are happening here in the SA node, the sinoatrial node. I can't remember if I mentioned this in the last time. So sinus, I always used to think like nose, what is this related to the nose? It's not related to the nose. It's called sinus or sinoatrial. The coronary sinuses, so the blood supply that goes to the heart muscle through the coronary arteries, and then it gets recollected in the coronary veins and drains back in. It drains into this right atrium, and so this sinoatrial node is near that sinus, near where the coronary veins are dumping into the atrium. That's why it's called sinus. It has nothing to do with the nose. Okay, so sinoatrial node, depolarization, that's going to trigger the depolarization of the entire atrium. There's kind of electrical insulation between the atria and the ventricles. And so the way to get the signal down to the ventricles that it's time to contract, the SA node passes the signal along, and that gets picked up by the AV node, the atrioventricular node. That's where the delay happens. And then the message gets sent along these bundle branches. You'll sometimes hear bundle of His. It's just this conducting pathway down to the ventricles, down to the apex of the heart, and then through the Purkinje fibers. Once you get depolarization in the Purkinje fibers, that's going to trigger depolarization of the entire ventricle, of all the cardiac muscle cells down here. That's loud and shows up on the EKG as this so-called QRS complex. The letters refer to these points where there's change in direction. And finally, repolarization as the ions go back to get the levels back to normal for the resting membrane potential. That's going to happen after depolarization, and it's going to be picked up as this T wave. Okay, now let's see departures from this normal sinus rhythm. So arrhythmias, how we can get something other than that normal rhythm is you can get spontaneous impulse generation from something other than the SA node. This is known as ectopy. Remember, the term ectopic means from outside, from somewhere other than where something is supposed to be happening. And so, for example, the AV node itself, the atrioventricular node itself, it also has this capacity, like the SA node has that automatic way of triggering itself to have a depolarization. The AV node also has that capacity. It's just that the SA node, the sinoatrial node, goes a little faster, and so kind of beats the AV node to the punch every time. I don't know if you've ever had a friend that's funnier than you are, and you think of a joke like a fraction of a second after they've already thought it, and they say the funny thing, and then you're left not saying anything because they beat you to it. That's the SA node and the AV node. They can both do this, but the SA node kind of usually beats the AV node to the punch. So AV node is usually suppressed by this faster SA node. If something goes wrong with the SA node, the AV node takes over. If your funny friend is not there, you're going to be the one telling the jokes. These are referred to as escape rhythms, as if the SA node was like this, domineering part of the heart, and I guess it kind of is. That's where the term escape comes from. It kind of escapes control of the SA node. Also, not just the node, not just the SA and AV nodes, but other cells that aren't pacemaker cells, other cardiac muscle cells can start to act like pacemakers. This usually happens under conditions of stress, like under signs of ischemia, extreme sympathetic nervous system stimulation. And then you can also have ectopic activity that throws in an extra beat. In addition, functioning part of the heart's like, oh, let's all contract now. And so then there's an extra beat that gets thrown in there. Let's see. This top tracing is showing normal sinus rhythm. And again, sinus doesn't have anything to do with the nose. It's the sinoatrial node. This is the normal rhythm. There's a P wave followed by the QRS. That means the ventricle is contracting. Then here the ventricles are repolarizing. And then we do it again. Notice that the P wave, this SA node depolarization, very quickly is followed by the ventricle depolarizing. It doesn't happen simultaneously because we've got an AV node that pauses for a moment before causing the ventricle to contract. So that's normal. If something goes wrong, the SA node, maybe there's some ischemia, that these cells die, they're not functioning properly, the heart's not going to stop. The AV node, you know, it's the less funny friend. It's the one that's not as fast, but it can still send signals. So when the SA node's working right, typical heart rate 60 to 100 beats a minute. If that's not working, the AV node's going to take over, but it's slower. It's the slower friend. So 40 to 60 beats a minute is standard when the AV node is in charge. So clearly we're going to get a weird tracing. We don't have any P waves because this part's not contracting, but we do still see some QRS. So the heart's still going to pump. Junctional escape rhythm, so junctional AV junction. And then finally, if that fails too, again, still not going to stop completely, the bundle branches and the Purkinje fibers also have this capacity, but they're even slower than the AV junction is. So you're going to get very slow and abnormal waves here. This requires a pacemaker. All right, so ectopic beats, they can come from other cells in the heart. So we can get some premature atrial contractions. It can happen. We can also see some premature ventricular contractions, or PVCs. This can also occur. It's not an emergency. This can also occur sporadically without having myocardial disease, especially some people are especially sensitive to caffeine, and you'll see more, increased PVC, or when they're stressed, you'll see these an increased number of these PVCs. You'd think it makes the heart pump more, but the thing is they happen too soon. It happens before the ventricle had a chance to fill, and so it's not very functional. It doesn't move very much blood along. And what causes it is hypoxia, ischemia, increased sympathetic tone, and hyperkalemia. Remember, the electrolyte imbalance can also impact heart rate. Let's talk now about conduction blocks. This is another problem that shows up. If the message from the SA node doesn't get through to the AV node, or the AV node isn't passing messages along the way it's supposed to, or it pauses too long, we call these conduction blocks. And the AV node it ages. It's susceptible to hypoxia. So we end up with this partial or sometimes complete block. That's going to lower the heart rate. And you'll see these non-conducted beats. I'll show you on the next slide. This is covered on these pages. Oh, not the next slide yet. Just a reminder of normal sinus rhythm. The pattern that you expect to see is that first lump is the P wave. Remember, this corresponds to depolarizations happening up in the atria with the sinoatrial node and the rest of the atrial muscle cells. When they depolarize, we're going to pick up on that with the so-called P wave. That's going to trigger the AV node to tell everybody in the ventricle, okay, now let's go. This is the big depolarization that's happening in the ventricle. This is known as the QRS complex. And then when the ventricle repolarizes, we're going to detect that again. We're going to, a bunch of ions are moving. That's the so-called T wave. So right before the ventricle contracts, we're going to see a P wave. So P wave, not a lot of time passes, and then the ventricle contracts. Another P wave, not a lot of time, and then the ventricle contracts, and so on. So P waves precede the QRS complex. That's standard. And the distance between the P waves is consistent. That's normal. On this diagram, I'm going to show you, on this slide, that this is atrioventricular block. The very first one is exactly the same diagram you saw on the previous slide. This is normal. There are the there are the P waves, and right after the P waves come the QRS complexes. All right, so atrioventricular block, we talk about it in degrees. The first, you don't have to do anything about first degree, and even second degree, depending on how bad it is. With third degree, absolutely something needs to be done. All right, so let's take a look. First degree, we're prolonging the PR interval. That is the time between the P wave and the ventricular contraction. The scales are a little bit off from each other, but I think you can follow this. We're going to look at halfway through. So here, this is a P wave right here. And notice there's this long lag before we get to the QRS complex. So that's prolonged PR interval. And R is that top point. So P and R here, P and R right next to each other. Here, P and R, there's this long delay. That's first degree. This just needs to be monitored. Nothing needs to be done. However, with second degree, the lag is so long between the P wave and when the ventricle finally contracts that sometimes there's not enough time for the ventricle to contract before the next P wave. And so here we have P wave then followed by a ventricular contraction. There's another P wave followed by ventricular contraction. Here's a P wave. Nothing. There's the next P wave. And so that's what we mean by, like, not all the P waves are followed by QRS complex. This can get extra bad, in which case there may need to be an intervention. With third degree, this is complete AV block. This could happen with somebody who's having a myocardial infarction or as a result of coronary artery disease, the worsening coronary artery disease and increased ischemia. So then there's the SA node is still doing its thing. It's still depolarizing, but the ventricle is not getting the message. And so there are P waves and there are QRS complexes, but man, they're not related to each other. The timing is all off. So this one requires a pacemaker. Tachyarrhythmias, so things are, the heart's beating too fast. This can result because of increased automaticity. Again, this is happening because of ischemia, extreme sympathetic nervous stimulation. This is common during myocardial infarctions. And then there's something called re-entry rhythms. It's explained in a number of different ways in our textbook. The easiest way I can think of this is think feedback. If you've ever been on a call or a Zoom session where, the information is supposed to be traveling that way and it's coming, like some of it's getting that way and some of it's coming back. These rhythm, like, so an action potential is being sent and it's traveling along a particular route, and then the wave kind of comes back, and you're getting feedback in a loop. That's a re-entry rhythm. It's also known as a circus rhythm. Circus, not like with elephants and bears doing tricks, but circus as in circle. It's a cycle, things coming back. This diagram shows it a little bit. We're not going to go into it in a lot of detail, but so you can have a visual on what's happening. What's supposed to happen is these signals are supposed to travel in one direction, and instead we're getting like this feedback coming back. And so for some people, this is the visual that works. The signals are just supposed to be traveling that way, and in fact it's traveling that way and then coming back and traveling this way, and so we end up getting a beat where there wasn't supposed to be a beat because we got this feedback. Okay, let's talk about atrial fibrillation. This is the most common chronic rhythm disturbance. Why it's so common is because it doesn't kill the patient immediately the way ventricular fibrillation can. So atrial fibrillation, patients can live with this. When it happens, there's no coordinated depolarization of all these cells at the same time. And remember, what we're picking up on the EKG is ion movements, like coordinated ion movements. There is no coordinated ion movement. The cells are depolarizing at different rates, and so we're not going to see any kind of discernible P wave. Then the QRS complex is the ventricular contraction that is irregular, because this isn't being well regulated, and the patient's pulse is irregular. We see it more with our patients who are aging. There's atrial enlargement due to hypertension. Remember, the cells hypertrophy, you get bigger. We get in heart failure, you'll see this sometimes, and with valve disorders. Okay, other environmental triggers or other triggers in the environment. You can have caffeine or alcohol intake can trigger atrial fibrillation in some patients, and lung disease can trigger this. And so the action potentials are being initiated by ectopic foci, meaning places outside of the sinoatrial node, and focus is a single place, foci is plural, multiple places in the atria can be sending the signals, and it's okay, everybody contract, and it's not coordinated. This is covered on pages 343, 345. This is continuing with atrial fibrillation. What's the problem? Well, one of the problems is one of the advantages of having atrial contraction is the ventricle gets filled a little bit more. And as we'll talk about in another section of this chapter, when the ventricle gets filled to this max capacity, it's going to be able to push really well. And so we compromise the ventricular filling. We lose atrial kick, that last little bit of filling the ventricle. So the heart's not pumping as much blood as it could, so the oxygen delivery system is impaired, and so the patients become more vulnerable to activity intolerance, again, because they're not getting enough oxygen. So you can't get oxygen, you can't make enough ATP, you can't make enough ATP, you can't contract muscles, you can't get your sodium potassium pumps to work right, etc. Because of the tachycardia, because the heart's spending a lot of time, within a minute, it's going to be contracted a lot of the time. That's going to shorten the period that it's relaxed, which shortens the period that it can fill. Also, when it's contracted, the coronary vessels that are going to feed the heart muscle itself, they're squeezed too, and so they can't deliver oxygen to the muscle, the cardiac muscle itself. So this makes the patient more vulnerable to ischemia of the heart muscle. And then, if those problems weren't bad enough, the third big problem with atrial fibrillation is the formation of clots. You'll remember Virchow's triad. We had, let's see, the 3 different things that lead to clot formation is circulatory stasis, being in a hypercoagulable state, and I'm blanking on the third one, it'll come back to me. But the part that we're dealing with here is the stasis, the atrial blood. Some of it's because the atrium's not contracting effectively and we're not moving the blood along very effectively. Some of the blood just kind of circles around in there and it's not moving, and that makes it easier for clots to form. So transient ischemic attacks can occur, and strokes can occur. So stroke is like a longer version of a transient ischemic attack. So these clots are leaving, they're going from the atrium, going through the ventricle, and then out. And they can go up to the brain if they're coming out of the left side of the heart. So patients who suffer from atrial fibrillation are often managed by keeping them on anticoagulants. And again, the reason for the concern is that because of the atrial blood just kind of circling around in there, there's a higher risk of forming these clots. Okay, and then finally, ventricular tachycardias. This is an emergency. Our textbook describes it as like arbitrarily we separated into these categories of short runs, 30 seconds or less, or longer runs. This is a real emergency. The short runs may be self-limiting. It's never great for this to happen, but if it stops on its own, it's not a medical emergency. If it goes on long enough, if the ventricle is pumping too fast, because of all of the reasons that we just talked about, the ventricle contracting, that means it doesn't fill very well. When it's contracted, the muscle tissue of the heart itself cannot be fed. It can't get enough oxygen. Then it can proceed to something called ventricular fibrillation, in which case we don't have coordinated contraction anymore. We just have kind of quivering. So the muscle cells are contracting, they're just not coordinated in their contraction. And so we're like, this is even less effective at moving blood around, in which case the heart itself is not getting oxygenated enough. And as you know, muscle cells cannot work if they're not getting oxygenated. And so eventually this can lead to the stopping of pumping altogether. What can cause this? The increased automaticity. All right, so you maybe have limited oxygen supply. That the hypoxia, ischemia, can lead to muscle cells starting to send out the signals on their own. This can also happen due to re-entry patterns. So we have that feedback, and so you can't get coordination because you're getting feedback in the system. So this is life-threatening. It can happen just due to heart disease, that the coronary artery is getting more and more choked if you will, the plaque is kind of choking off the blood supply. And that's going to limit oxygen, and the cells can die. This is an infarction. It can also result from some rare genetic disorders. I'm not going to go into any amount of detail on this. We've talked about the different ion channels, sodium channels, potassium channels that have to be in the cell membranes in order to allow these ions to move, in order for all of this coordinated activity to happen. There are genetic mutations. So go back, the ion channels, of course, are proteins. Proteins are coded for by genes. If there's a mistake in the gene that codes for that protein, then your protein's not shaped quite right, and it may not do the job quite the way it's supposed to. And so there are a few different genetic disorders that are known that result from mutations in genes that code for these ion channels. A couple of examples: Brugada syndrome, and there's a variety of different long QT syndromes that are due to mutations in either sodium channels or potassium channels. And that's all I'm going to say about that. And that is the end of part 2.